Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. Thanks for joining us today for the last webinar in our cardiac series with renowned emergency physician and educator, Dr. Thomas Cook. You're among 3,800 clinicians who registered for today's popular session, Cardiac POCUS Part 3, Resuscitation with Handheld Ultrasound. There's a high mortality rate in patients presenting with undifferentiated shock. The good news is that point-of-care ultrasound, in particular the RUSH protocol, can play an important role in reducing diagnostic uncertainty. In a moment, Dr. Tom Cook will share life-saving POCUS techniques for evaluating and managing shock to guide effective treatment and resuscitation. You can use the questions icon at any time during today's session to ask questions. Dr. Tom Cook will address your questions in a live Q&A following the presentation. Let me now introduce you to your host for today's event. Dr. Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as chairman of our medical advisory board. Welcome back, Dr. Frankel.
Thanks, Jeanette. Good to be here on a topic that's particularly relevant to my personal practice. And as I can attest that hemodynamic assessment is critically valuable in many areas of clinical care, including what's obvious to me and Dr. Cook, our guest, is that it's really helpful in emergency medicine and the emergency department. But what I wanted to highlight in setting up our discussion today was how useful these techniques can also be outside of the emergency department and where clinicians can still benefit from ultrasound-assisted hemodynamic assessment in multiple other areas of clinical care. The first one I was going to cover, which is adjacent to the emergency department, would be the critical care unit or ICU, where a global assessment with point-of-care ultrasound can yield critical information on fundamental hemodynamic measures and signs of organ congestion, fluid tolerance, or responsiveness that can guide management of these sickest of patients in a much more nuanced and powerful way than traditional non-invasive hemodynamic monitoring alone could accomplish. The next study I wanted to just highlight here is another area where we're seeing growth of these techniques, which is in perioperative medicine, where similarly, ultrasound can fill in the details that the non-invasive hemodynamic measurements are obtaining and can allow in situations for targeted interventions that can guide fluid, vasoactive, inotropic medications, and it can optimize patient perfusion, especially when they're sicker in the operating theater. And lastly, I wanted to bring up this experience that I loved from an inpatient ward where a life was saved by deploying a point-of-care ultrasound rush exam. It really highlights how point-of-care ultrasound guided resuscitation protocols for any patient in shock can revisit and hone diagnostic strategies. It can identify diagnoses that us clinicians may not have thought of or been aware of initially, and can finally guide us to ultimately the treatment that our sickest patients need, especially when our urgent answers are required. So before we jump into the meat of today's discussion, we have clinicians from across the globe at various uses of practice, and just wanted to put it out there, how frequently do you use ultrasound for resuscitation support? Is this something in your daily practice, maybe a little less frequent, or are you just learning today? And we are going to close that poll out here. Quick question. And just to see where we're at, great. So we're across the board, and we think that everyone has something to learn today from our esteemed speaker, Dr. Cook, whether you're learning or you're already a daily user. Dr. Cook began his active duty in the U.S. Army, and when he left in 1996, he joined the Faculty of Emergency Medicine residency at Prisma Health in Columbia, South Carolina. And shortly after this, he founded Third Rock Ultrasound, an education company designed to help all healthcare providers integrate ultrasound technology into their practice. Over the last 2 decades, Third Rock has presented courses on over 1,500 occasions throughout the United States, as well as Europe, Africa, and Asia. And since 2001, Dr. Cook has also been the program director for emergency medicine with Prisma Health, University of South Carolina School of Medicine. Dr. Tom Cook, I'm going to hand it over to you.
Thanks so much, Rod. It's great to be back. I love doing these webinars, and I love talking about ultrasound. It's really a thrill for me. And I think this might be, my favorite of all the lectures that I do. And it'll tie in some of the things we discussed in our last 2 webinars, looking at left ventricular failure and right ventricular failure. So we'll pull in some of the principles from that as well as we go through the lecture. In terms of what our objective is, it's pretty simple. We're going to talk about how to use ultrasound to assist in the diagnosis and management of shock. And of course, these are the patients that are the sickest. And of course, it makes everybody a little bit nervous. And this really provides some incredible clarity on how to manage and manage these patients and really simplify the whole process. So RUSH is, of course, an acronym. It's very analogous to the FAST exam. RUSH stands for Rapid Ultrasound and Shock and Hypotension. And the phrase was coined back from this paper back in 2010, so 13 years old now. And if we consider the FAST exam, which of course is focused assessment with sonography for trauma, it is an examination protocol in which you start with examining the right upper quadrant, then the subcostal view of the heart, the left upper quadrant, the pelvis, and then after this original FAST came out, we went to eFAST, in which we also examined the lungs. For RUSH, we don't look at the left upper quadrant, we don't look at the pelvis, we just take a much more thorough look at the heart, and we also look at the inferior vena cava. And we'll discuss why that is as we go through the lecture. But let's start with a case. So you get a call about a patient coming in by EMS, and they're breathing real hard, and they're sweaty, and they're not thinking right, and they've got really terrible vital signs. They're tachypnic, they're tachycardic, they're hypotensive, and they're hypoxic. And if you throw in the altered mental status, that's 5 abnormal vital signs. You can't find a sicker patient than this. And of course, when you get these sort of patients, you start thinking, well, what's causing the problem? What are the possibilities here? Is it something to do with their heart? Do they have decreased myocardial function? Are they in heart failure? Do they have a pericardial effusion? Or is it something with the lungs? If they have an exacerbation of COPD or pneumonia, or maybe a pulmonary embolus, or this is some pleural-based problem like a pleural effusion or pneumothorax. It also could be due to hypovolemia from internal bleeding, such as an aortic aneurysm or an ectopic pregnancy, or of course, a relative hypovolemia, which is what we see in sepsis, or it could be other things, some type of intracranial pathology, some type of toxicologic problem, or maybe an endocrine problem. Or, hey, guess what? It could be a combination of things. We always see lots of sick patients who have more than one problem. So we have to consider that it's not just a single thing. If we consider that patient I just presented to you, they have a problem list, which is pretty terrible. They're in shock, they're hypoxic, they have respiratory failure and altered mental status, and all those things, of course, can kill off the patient. What's great about ultrasound is we can use this technology to, within a few minutes, help us with the diagnosis of what it possibly could be, but more importantly, what it isn't. And finally, to help us manage the patient effectively and go in the right direction right from the get-go. So what is shock? We know this is end organ hypoperfusion, particularly the heart, the lungs, the kidneys, that type of thing. And there are 4 basic types of shock. We talk about these, we learn about these in medical school. So cardiogenic, hypovolemic, distributive, and obstructive. But I just like to simplify the discussion here to say that shock is a decrease in pressure in a closed vascular system. Furthermore, I'd like to simplify this system to say that it's just made up of a pump and some pipes. And if you think about this very simple system, there are 4 ways that you can lose pressure within this simplified system, the simplified vascular system, which I'm presenting to you now. The first one is that the pump fails. It isn't able to push fluid through the system. And this is what we would consider or see in patients who had heart failure, particularly left ventricular failure, but also people who maybe had heart failure secondary to valvular disease or some type of myocardial infarction or some other type of event where you have myocardium that's not getting enough oxygen. The second way that you would lose pressure in the system would be that the pipes leak. And of course, this can be something that you would see in trauma, where you'd have internal bleeding, but you may also see this with non-traumatic internal bleeding from, say, a ruptured aortic aneurysm or an ectopic pregnancy. The third way that you can lose pressure in the system is that the pipes suddenly expand for no apparent reason. And this is what we would see in, say, somebody who had septic shock, but we also may see it in somebody who has neurogenic shock or anaphylactic shock. And the fourth way that you would lose pressure in the system is that it becomes obstructed. And this is what we would see if somebody had a large pulmonary embolus or a pericardial effusion or tension pneumothorax. So those are the 4 ways that we would lose pressure within this system. And the RUSH protocol will very quickly help us figure out what type of shock we're dealing with and also guide our management in just a few minutes' time. So the rush protocol, as I pointed out again, consists of examining 4 areas: the heart, the inferior vena cava, the pulmonary system, and of course the peritoneum. And you always start out with the heart. You really have to figure out what kind of a pump you're dealing with. If you have a great pump, it's going to push you one way. And if you have a heart that's not functioning very well, it's going to move you in a different direction. So on the left side of the screen, you see left ventricular failure. The left ventricle doesn't pump very well. This is somebody who's either has a long-standing heart failure or perhaps some acute event. And on the right side of the screen, you see somebody has right heart failure. The right ventricle is gigantic when you compare it to the left side of the heart. And so this would be somebody who has isolated right heart failure. Or you may have some other problem going on with the heart. As you can see on the left, the pump is great, but it also is beating very, very quickly. And if you look at the ejection fraction of the left ventricle, it is extremely high. And this is what we refer to as hyperdynamic heart. This is a heart that's not getting enough preload. It doesn't have enough blood to pump. And then on the right side of the screen, we see obviously somebody with pericardial effusion. And we also see in this situation that the right ventricle, the free lateral wall, dents into the right ventricular chamber during systole, and this is an indication of tamponade. What's also interesting about this case, if you look at it carefully, there's one big abnormality why this person has pericardial effusion, and that is that the aortic root is gigantic. So this was a patient that had a dissection where the blood had in fact come around the heart inside the pericardium, causing this pericardial tamponade. Now, after you look at the heart and you figure out what you're dealing with there, then you're going to go look at the inferior vena cava. And this is, of course, very important to give us some idea of relative volume status. On the left side of the screen, we see a very dilated inferior vena cava, and the pressure is so high that it's also dilated the hepatic vein. So the relative intravascular volume is very high. On the right side of the screen, we can see that the inferior vena cava is flat. So Oran likes to say full or flat, and I couldn't agree more. Let's make it very simple. And on this side of the screen with that flat inferior vena cava, this tells us that the relative intravascular volume is very low. And that, again, is a very important factor in helping us understand what direction we need to take in management.
Actually, Tom, I like fat or flat.
You like fat or flat?
Fat or flat. It makes it just roll off the tongue easier.
I got the 2 F's right. So full or flat. We'll go with fat or flat. I like that better too.
Fat or flat.
Okay. So on the pulmonary side, that's the third thing you're going to look at. So you looked at the heart, you looked at the inferior vena cava. Now you're going to look at the lungs. And we're looking mostly for 2 things. On the left side of the screen, this is very obviously pulmonary edema. All right. And you can see these very prominent beam lines on the left. And on the right side of the screen, we have pneumothorax, where we see no evidence of pleural sliding at all. So those, of course, would be 2 important things to pick up on that. And then finally, the fourth area you're going to look at is the right upper quadrant to see if there's free fluid in the peritoneal cavity. And, maybe upon seeing that type of thing, it would spur you to look in different areas. In the left side, you see a large aortic aneurysm. And so if you were leaking, hopefully not ruptured, but leaking, you would see fluid accumulate in the right upper quadrant. And on the right side of the screen, wow, that's pretty impressive. This is the uterus, and this is an ectopic pregnancy, which also could be leaking. And in fact, in that case, was leaking, and that helped us figure out what the problem was. Now, you've done those 4 things. You're going to pick up some clues about what you need to do. And then you have to figure out what's your first step in management. And that's going to be either intravenous fluids or drugs. Now, if you have a normal heart, you're going to give fluids, all right? And fluids can be ringers, it can be normal saline, it could be blood products, anything that's going to expand the intravascular volume. Now, if you have an abnormal heart, you're more than likely going to have to lean on drugs. You're going to have to give this person drugs in order to keep their pressure up and get them out of shock. So with all that information, let's go back to that first case. Remember, this was a real sickie, right? Tachycardic, tachypnic, hypotensive, hypoxic, confused. They were sick. And so the first thing we're going to go do is look at their heart. Obviously, this is a parasternal long axis, right ventricle, left atrium, aortic outflow. And hey, you don't have to be a genius here. That left ventricle is a pretty sad thing, right? You got no fractional shortening at all. Mitral valve excursion, it doesn't even go halfway. This is a very dysfunctional heart. This is a very poor pump. So that's an important piece of information right there. Next thing we're going to go do is look at the inferior vena cava. And what do we see? Well, it's dilated, and we also don't see a lot of variability with respiration. Remember, when you breathe in, you're creating a negative pressure in your chest. You're creating a vacuum, and it's going to pull the blood from the inferior vena cava into the heart when you breathe in. And you don't see any variability in the width of this at all. And that tells you that you have a pretty high central venous pressure. Of course, the next thing we'll look at is the lungs. And wow, pretty easy to see this person has a lot of B lines, a lot of pulmonary edema. And then we'll look at the right upper quadrant, and we don't see any evidence of free fluid. So we've got some very important information now. We just need to put this together in our head. The heart function is terrible. The intravascular volume is very high. There are B lines in the lungs, there's pulmonary edema, and finally, there's no intraperitoneal bleeding. So based just on a few minutes of scanning, we know this patient's not hypovolemic. They don't have a pneumothorax because you can't see B lines if you have a pneumothorax. They probably don't have a pulmonary embolus because the right ventricle wasn't very big on your cardiac exam, and they don't have any evidence of intraperitoneal bleeding. However, we do know this patient has heart failure, hypovolemia, and pulmonary edema. And we put all those together and we say this patient has cardiogenic shock. Now, we know the diagnosis. We know what we need to do. The question is, what's our first management step? And of course, none of us are going to give fluids in this particular situation. We're going to rely on drugs to manage this patient. So if they need blood pressure support, we would use some type of pressor, usually Levophed. We would give them Lasix. We would give them BiPAP and those types of things. Now, let's go to another case. This is a real crazy one. You're never going to see a case like this. This is an old person with abdominal pain. Very rare, very rare. So this old guy comes in, he says his belly hurts and he's sweaty and he's dizzy. And we look at those vital signs and go, oh, wait a minute here. He's tachycardic, he's tachypnic, he's hypotensive. His oxygen saturation is okay, but 3 out of 4 don't look good. So we go look at this guy. And the first thing we notice when we look at his heart, and this is obviously an apical 4-chamber view, and here's the left ventricles, man, that left ventricle is really doing great. I mean, it's pumping so hard, it's got an ejection fraction of like 97%. He's squeezing every last red blood cell out of that left ventricle. And he's doing that because he wants to keep his blood pressure up. The problem is that he probably doesn't have enough preload to load that chamber effectively. So let's go look at his inferior vena cava, and yep, that thing is flat. We have a relatively low intravascular volume, and we've only spent maybe a minute examining this guy. The next thing we'll do is go look at the lungs. And what do we see? Well, we see some sliding, and we don't see any V lines, so that all looks pretty good. And then we'll go down and look at the peritoneal cavity, and whoa, wait a minute, what's going on here? There's some blood there, and there's some blood there. Of course, this is the liver, this is the kidney. So we have intraperitoneal fluid, which we kind of have to assume is blood, right? And the next thing we probably need to do is look someplace else. But let's just summarize what we know so far. The heart, it's beating fast, but it beats well, okay? It's a good heart. It's a good pump. The volume is low, the lungs are normal, and there's free fluid in the belly. So what kind of a shock do we have? Well, we have hypovolemic shock, right? That's the picture that we have now. And because we're very smart and good with our ultrasound, it's going to take us an extra 15 seconds. We're going to move right down to the aorta and see this is the sagittal cut that he has an aortic aneurysm. So that's the source of his shock. All right, let's try I should say the treatment for this is pretty obvious, right? Obviously, he needs fluids, but he also needs a surgeon. So we need to prep this guy for the operating room. We need to call the surgeon to come in right away and take care of this patient. Now, case number 3, another crazy case. It's another old person with abdominal pain. 2, I can't believe it, the same day. All right, abdominal pain, sweaty, dizzy, same thing as the last person. And they're also vomiting a lot, okay? Now we look at them, and wow, they have the same vital signs as the last case too. This is a carbon copy, tachycardic, tachypnic, hypotensive, same saturation, they're bookends. So let's go look at this patient's heart. Now, of course, this is parasternal long axis. Here's the right ventricle. It's a little generous. The left ventricle here, left atrium, aortic outflow. And immediately we can see that this person has poor left ventricular function. Fractional shortening is not so good. Anterior leaflet of the mitral valve does not make contact with the septum. If you're a MAPC fan, you can see the annulus really doesn't make any movement towards the apex of the heart. This is left ventricular failure. Moving on, let's go and look at the intravascular volume. We're going to look at the inferior vena cava. And what do we see? Up, it's flat. All right. Very low intravascular volume. Probably not what we were expecting, but a low intravascular volume. Next thing we'll do, of course, is we're going to look at the lungs. And what do we see? Well, normal sliding, no B lines. That looks pretty good. And then, of course, we're going to finish off real quick and look at the peritoneal cavity. And we don't see any free fluid there. So now it's time to put all this stuff together. What do we have? We got a poor heart. We got a low intravascular volume. The lungs are normal and there's no free fluid. So what kind of shock are we dealing with now? This is a little different than the last case, right? Because the last case had a normal heart and this one has a poor heart, but the patient still has hypovolemic shock. And this is a real important teaching point here. Just because you have chronic left ventricular failure doesn't mean you can't have other forms of shock. As I mentioned a while ago, a lot of our patients have more than one problem. And their chronic problems, of course, put them at higher risk for really bad outcomes. But it's certainly possible to have chronic left ventricular failure, but also have hypovolemic shock or distributive shock or obstructive shock. And this particular patient has hypovolemic shock. So now you have to play this, balancing act. Like, can I use some fluid in this patient because it is a hypovolemic shock case? Or how do I need to, go to pressors right away? Or is there some sort of balance I go for? So, when you say to yourself, can I give fluids to somebody who is in hypovolemic shock with heart failure? What you're going to use is ultrasound to guide your fluid management. And this goes back to the old Frank Starling curve when we were all studying cardiac physiology in medical school. And we knew that if we increase left ventricular end diastolic pressure, which is another way of saying increasing your preload, we got more and more cardiac output until we plateaued at a certain level. And that was the normal with normal left ventricular function. But when we had moderately or severely depressed cardiac function, this is when we got less bang for buck. We could increase the preload, but we didn't necessarily get the same amount of cardiac output. But we still got some. And that's the point that I need to make here, is that we still got some. So you still can use some fluid here. So if you have chronic left ventricular failure and your IVC is flat and you're relatively hypovolemic, you can give this person small boluses of intravenous fluid, 250, 500, whatever you think is appropriate, and then monitor the intravascular volume by ultrasound. So you're looking at, a situation where the IVC is flat. And then over time, what you'll see is that it becomes wider and wider and less compliant. You have a situation right here where you need to move on to drugs. So when you hit that point, you're going to stop the IV fluids and you're going to go to a pressor, most often Levofit. Now, how do you sort of judge these when you see an inferior vena cava? How do you judge when you need to use fluids or when you need to use drugs? It's really very simple. If you're looking at the inferior vena cava and it's wide and it's stiff, don't give them fluid, all right? And if you're looking at it and it's narrow, or as Ron likes to say, flat and compliant, we give IV fluids. And what about if it's wide or fat, as Ron would say, but it's compliant? Well, IV fluids might help. So this is another case where you're looking at an inferior vena cava and it's big and wide, but when the person takes a breath and creates that vacuum in their chest, it pulls blood out because it's moving out of the inferior vena cava. And this is a situation where, you're going to give some fluid and see how the patient responds to it. So really what you're going to do is use ultrasound to judge, to gauge or to help you manage how much fluid you're going to give to the patient versus giving them drugs. All right, next case. This is a total setup. Everybody gets the diagnosis, but it's a long flight. The patient comes off the plane. They have chest pain and shortness of breath. They also have some medical problems, diabetes and hypertension. And wow, what a surprise. They're in shock. They are tachycardic. tachypnic and hypotensive and hypoxic. So they've got all the baddies. And we go and we look at this patient. Of course, this is an apical 4-chamber view, and the right ventricle is massive. All right. And that's one thing you pick up. But when you see a massive right ventricle, you got to look real quick at that left ventricle. Okay. If the left ventricle is massive and failing, remember the most common cause of right heart failure is left heart failure. But in this situation, the right ventricle is gigantic and the left atrium is small. It's got a very high ejection fraction. And the left atrium is also very, very small compared to the right atrium. So there's big pressures on the right and there's relatively low pressures on the left. So that's an important thing to pick up. The next thing we'll do is look at the inferior vena cava and we say, oh, wow, that's fat and it's not compliant. So we have very high central venous pressure. We have high intravascular volume, relatively speaking. We look at the lungs and we see no evidence of pneumothorax or pulmonary edema. And we look at the right upper quadrant and we don't see any evidence of intraperitoneal fluid. All right, let's summarize. We've got a big right ventricle. We have a high intravascular volume. The lungs are normal and there's no free fluid in the peritoneal cavity. And so we can look at this and say, this is somebody who has obstructive shock, okay? And this is a little bit different because now the treatment is really based or depends on what the cause of the obstructive shock is. So in our case that I just presented with the woman getting off the airplane, this is obviously a pulmonary embolism. You can see these two gigantic emboli causing her problem. And if she doesn't get treatment, she's not going to do well at all. So what you're looking for with pulmonary embolism is a large right ventricle, a small left ventricle, and a large inferior vena cava. And if they're unstable, which our patient is, every single vital sign is abnormal, we now have a pretty standard protocol throughout the United States and Canada. Well, what we're doing is a 3-drug protocol to stabilize these patients. So the first thing we need to do is stabilize their blood pressure, okay? If they're in shock, we want to try and get that up. And so the drug that we use most often now is norepinephrine or Levophed. The second thing we want to do is stop them from having clots. So we're going to give them some heparin, and we're going to give them a lot of heparin. And then we need to use some kind of a thrombolytic. So here's the protocol: massive pulmonary embolism causing shock, norepinephrine drip, heparin. We want to give them a big bolus and a drip, so 5,000 units or more, and then a thrombolytic, which could be alteplase or tenecteplase. Now, my hospital has just recently gone to tenecteplase for a lot of reasons that I think are very good. Alteplase or TPA it only lasts about 5 minutes in terms of its half-life. It's gone after a little more than an hour. And tenecteplase, its half-life is 20 minutes and it hangs around for over 2 hours. So it lasts a lot longer. The preparation's about 5 minutes of monkeying around getting this drug ready, but only 1 minute on the tenecteplase. And the administration for alteplase is a bolus and an infusion over an hour, while tenecteplase is just, one bolus, which is weight-based. So it's really a lot easier to give, and it's becoming more and more common to use this drug, not only for pulmonary embolism, but, for myocardial infarction and even stroke. We're using it for all 3 of those things in my hospital now. All right, couple of pearls here. What about intravenous fluids for pulmonary embolism? I mean, you're in shock, the heart's fine. Why aren't you, the left ventricle's pumping away. Why aren't you giving any fluid here? Well, here's another case. It's a 41-year-old woman. This is a woman I saw maybe 15 years ago. And she syncopized at work. And, the EMS shows up and she's tachycardic and hypotensive and just passed out. And they do what they do per their protocol, and they give her a bolus of intravenous fluid. Now, shortly after that, she goes into PEA. So what's going on here? Remember, when you develop a pulmonary embolus, you're effectively blocking blood flow to the left side of the heart because you've put an obstruction there. When that happens, the blood backs up and starts to enlarge the right side of the heart. The problem is that the heart is inside the pericardial sac, which we all know is not very distendable. And not only is the left ventricle not getting the usual amount of blood, the usual amount of preload, but the right ventricle's expansion is basically squishing or cannibalizing the left side of the heart. And you not only drop your stroke volume, you basically obliterate and have no stroke volume. And that effectively kills the patient. So when that patient arrived in our emergency department, this is an apical 4-chamber view, and it's a very old study. It's very grainy, but it's very easy to see the right side of the heart here and lots of little bubbles. That's from the intravenous fluid that went in. It's not pathologic at all. And you can see the left ventricle is completely obliterated. And so the intravenous fluids in this situation basically exacerbated or accelerated this patient's demise. So you don't want to give fluid in patients with pulmonary embolism. That is a very, very important point. Now, what about pericardial tamponade? So in this situation, we have fluid all the way around the heart, and it's compressing both sides. It's compressing the right, and it's compressing the left side of the heart. Right is affected more because it has lower pressure, but still it's compressing both sides of the heart. So you'll see a small right ventricle, small left ventricle, but you'll see a large inferior vena cava. And the other thing you have to see is evidence of tamponade. So this is what I showed you a while ago. This is the patient that has left ventricle, pumps fine, but just doesn't have a lot of preload. It's doing whatever it can to try and generate as much cardiac output as possible. Here's the right ventricle. And if we look at the free wall of the right ventricle, when it goes into systole, that loses so much pressure that it starts to have this concave motion into the right ventricle. As I mentioned, this gigantic aortic root here, this is somebody had dissection, this is all fluid around the entire heart in the pericardial sac. So that's pericardial tamponade. And of course, we know the treatment for this is aspiration, and that's another lecture on ultrasound guided procedures. Now, how about pneumothorax? The same thing with pericardial fusion. You're compressing the entire heart. So the left and right ventricles are small. The inferior vena cava is large, which you see here. And this situation is often kind of tricky because you have to keep in mind that because there's so much air in the chest caused by this pneumothorax, it's often very, very hard to see the heart. And sometimes the only view you can get is the subcostal view, which is not usually the best view of the heart. So you have to, think about, I need to go look if there's no sliding and this person is in shock, then I need to go ahead and decompress the lung. All right, last pearl. Remember, with AAAs, the reason we get to see them if they're from outside the hospital is that they have a retroperitoneal bleed, not an intraperitoneal bleed. So you may not see any blood in the intraperitoneal compartment, right? You may not see free fluid. It's all retroperitoneal. And that's good for the patient because it hurts like hell, but it also tamponades the bleeding and they stay alive. If it starts going intraperitoneal, if it's in the field, they usually just exsanguinate. If it's in the hospital, I don't know, maybe you can save them. But, just keep that in mind with your AAAs. All right, last case. We have a couple teeny cases, but the last full case. So this is a guy I saw maybe 20 years ago, but it's a great teaching case. So he's confused, and he's this guy who lives alone. He's kind of a little demented, and the family checks in on him kind of thing. And they say, well, he was more confused than usual this morning, has no other complaints. He's got some hypertension and diabetes. If you look at his vital signs, they're not too bad, right? I mean, he's a little hypertensive, but, that's not too bad for an old guy who's a little confused. And we got an EKG on him, and, it really looks fine. I mean, it's normal sinus rhythm, no evidence really of anything too significantly bad. And we get a whole bunch of laboratory studies because that's what we like to do in the emergency department. And we even get a troponin and we scan his head because we think, well, he's got altered mental status, and that's all normal. And we're just rounding that day with some medical students. So we're going to go ahead and just look at him and talk about ultrasound. And again, it's an old view. This is subcostal. You see a little bit of the left lobe of the liver here. And here's the right ventricle and here's the left ventricle. And they both pump really well. I mean, they work well. Now, his atria are gigantic. And this is all, 99% of the time, this is just chronic hypertension. But that's what we see. And so there's nothing really to get excited about there. And we look at his lungs and they're normal. And we look at his inferior vena cava and it's full, but it's very, very compliant. When he breathes, it collapses appropriately. So we say, hey, this is pretty good cardiac function. We've got some evidence of chronic hypertension. And we move on and start looking at other patients. About 30 minutes later, our nurse comes up, or his nurse comes up and says, that guy just collapsed. He's in cardiac arrest. And so when we get there, we see he is in PEA. And when we go and look at his heart, the same heart that we looked at 30 minutes earlier, again, Here's the right ventricle. Here's a little bit of the liver. Here's the left ventricle. You can see that there's all this particulate matter. These are small blood clots that have started to form. And there's no coordinated contractility of this heart. There's no way this heart is pumping blood to generate a blood pressure. And so we start a resuscitation of this particular patient. Now, let's talk just a little bit about cardiac arrest and how we're going to use ultrasound. When should you use it? If the patient has a shockable rhythm, so this could be pulseless ventricular tachycardia or even just ventricular tachycardia or a ventricular fibrillation, you should shock them first and save the ultrasound for later. On the other hand, if the person's in pulseless electrical activity, this is when ultrasound can help you figure out what you can fix and what you can't fix. So the stuff we can fix is pretty obvious, right? Pericardial tamponade, pulmonary embolus, hypovolemia, and pneumothorax. And this is what we sort of do, what we were taught a long time ago in med school, but it's much simpler with ultrasound because you can actually make that diagnosis instantaneously as opposed to kind of futzing around, which is what we did all those days, all those years ago when I started out. So when you do have PEA and asystole, of course, this becomes very, very hard to, there's no sort of procedural thing you can do to sort of treat them. And we just start to utilize a lot of epinephrine and CPR. So what are you going to see when somebody has PEA or asystole? Well, obviously, you don't see any evidence of cardiac output. You'll see the blood maybe not flowing in the right direction. It might be going the opposite way through the valves than you would expect. And you'll see the formation of blood clots because it doesn't take long for that blood just rolling around in those cardiac chambers and it starts to clot. So our management, as I discussed, we're going to use epinephrine, a lot of CPR, and look for reversible causes. Now, this is a great paper, came out, 7 years ago now, where they looked at out-of-hospital cardiac arrest, and they did ultrasound, and they looked at these patients, and they said, if they were in PEA, what was their overall survival? And less than 1%. That's really low. That's about zero. It's basically saying you got a dead guy here. So that's really impressive. Now they did get patients back, and they got to the emergency department. They maybe even got admitted, but they didn't survive. And that's the point to take home here. When they're in PEA in the field, they're not going to come back. Now let's go back to this fellow that we were taking care of. If you remember from the ultrasound and the labs that we did before this person went into arrest, we knew he didn't have hypovolemia. We looked at his IVC, it was normal. We knew he didn't have a pneumothorax because he did an ultrasound of his lungs. He didn't have a pericardial effusion from his ultrasound. He didn't have hypoxia from his vital signs. He didn't have hypothermia from his vital signs. He wasn't acidotic based on his serum chemistries, and he wasn't hyperkalemically either because all those labs were normal. So we've effectively ruled out all those possible things very, very quickly. And because of this, after we ran this code for about 20 minutes, we stopped the code and pronounced him dead. So PEA by ultrasound very often means, particularly in out-of-hospital cardiac arrest, that this is a lethal event that the patient will not survive. I've certainly had lots of patients that I've been able to resuscitate with PEA, who've had PEA in the emergency department, if they arrested in the emergency department, and even sometimes out, but they have very, very low survival rates, even after they get admitted to the intensive care unit. Now, as with everything, you got to remember there's some caveats to these rules. And they are, if the patient's a dialysis patient, we see this a lot, okay? Their potassium's too high, we're going to give them calcium, we're going to give them sodium bicarbonate, we're going to give them insulin and D50. Also with kids, little kids, very often it's a problem with hypoxemia. We give them some oxygen, do a little CPR, a little epinephrine, and they spring back to life. And, the whole thing about hypothermia, they fall into a frozen lake, which is up there for those Canadians that I work with. But we don't have a lot of frozen lakes down here in South Carolina where I am. So not too much of that. Now, let's just do a couple of quick cases. And these are literally cases I've seen maybe in the last 20 days. So we look at this one, right? This is parasternal long axis. This is somebody in cardiac arrest. And you can see that this person has essentially no contractility at all, right? You can see this, the mitral valve leaflet, it's kind of floating around a little bit, and the left atrium is really big, but there's no evidence of contractility. So we don't see anything. We start CPR, we give them some epinephrine, we do a couple rounds of this, And, what we end up getting back, this is obviously an apical 4 here, is that you can see the left side of the heart is full of bubbles, right? These little white things floating around. They're not bad at all. That's just because he's got an epinephrine and a little bit IV fluid, but the heart is now contracting. And so this person generates a pulse. And of course, we do all the usual things that we try to do in terms of stabilizing the patient. He gets admitted to the intensive care unit. And here's another one. We're looking at this patient. This is actually a subcostal view here. And we say, gosh, not much, right? It's just not moving very well at all. You can see that there's nothing here. There's a little contractility, but it's nothing that you could generate a blood pressure off of. And then we go ahead and go through our resuscitation. Same thing, CPR and some epinephrine. And now you see some contractility, and we see a pulse. Now, there are times where people come in and that nobody feels a pulse. Or we're resuscitating, nobody feels a pulse, and we look and we see they have great left ventricular function. This is a situation where we can say, let's give them some volume, let's give them some more epinephrine, see if we can get a pressure. But these are two very, very common scenarios that I pretty much see all the time. Now, final thoughts. Just remember, what's great about ultrasound and shock is that it's fast, okay? And it gives you incredible information very, very quickly, and it helps you figure out what direction you're going to go into. And the 4 things you're going to look at: the heart, the inferior vena cava, the lungs, and the peritoneal cavity. Before I conclude, just a shameless plug for my work with Third Rock Ultrasound. We teach ultrasound courses all around the United States and sometimes overseas. And we do have some courses coming up. In fact, next week we'll have a course here in Columbia, South Carolina. That's my home. We'll have both an introductory course and an advanced course. We still have some seats available. And then in June, we'll be, we'll be in Las Vegas. And again, we'll have an introductory and advanced courses. I believe we have a critical care course as well. So that concludes my talk. Again, so thankful that I've been invited to speak. And I'm going to turn it back over to Iran.
Awesome for that great presentation. Thanks so much, Dr. Cook. There's a lot of questions in the Q&A, and we are going to get to as many of those as we can. Please keep using the Q&A tab and keep filling in. We will get to that really shortly. Before we get there, I'm going to hand it over to Shelley Gunther, our clinical marketing manager, for a quick demo.
Hi, thanks, Iran. Great talk, Dr. Cook. Working in the echo lab, we usually don't see things in an acute situation like you do. So those are some pretty great studies. So I'm just going to switch my camera over, and I will start sharing my my screen here. So I'm just starting with the PA scanner, like Dr. Cook uses, and I'm going to just start in the parasternal long axis window, and I'm using the auto preset, which is up here. It recognizes that I was looking at a cardiac window and switched over to the cardiac preset. So right away, because my patient's on his back, I'm getting a little bit of a vertical look at the left ventricle, but we can see really good contractility of the myocardium here. We can see the anterior mitral leaflet touching the interventricular septum. And we're getting really good mitral annular excursion here. So I would say, generally speaking, we could say that this is very normal left heart function. Would you agree, Dr. Cook?
Yeah, it looks a lot better than those last 2 cases I looked at.
Absolutely.
I think this guy's a keeper.
You're going to make it. One other thing to notice, that if we were going to be seeing a large pericardial effusion, it would be just kind of around this area here. And obviously we're not seeing anything there. So next, I'm just going to move the scanner down to the midline of the abdomen. And right away, the system switches over to the abdominal preset so that I can have a really nice look at the inferior vena cava. And we can see it varying with respiration as he breathes. It's just a nice size. What we don't want to see is anything, over about 2 centimeters, which we could kind of gauge with the depth markers on the side. And one other thing that Dr. Cook showed was, a very enlarged hepatic vein, which, we're certainly not seeing here, very normal. And then we'll zip down to the right upper quadrant. And again, take a breath in. We'll see the nice view of Morrison's pouch here. Definitely no intra-abdominal fluid, or retroperitoneal fluid, I should say. And then the last place we'll look is just go up to the chest and we'll have a look at the lungs. And again, we've switched over to the lung preset automatically, and we're seeing really nice lung sliding here. No B-lines, no evidence of pneumothorax. And that's your rush exam. So pretty quick and easy.
Thanks, Shelley, for the quick demo, and it sure
Thanks.
shows how effective and quickly you can get so much clinically useful information. I see there's more and more questions coming in on the Q&A, and we're going to have time to get to those in just a minute. I'm going to hand it first back over to Janez.
Thank you, Dr. Frankel, Dr. Cook, and Shelley. Before we open up the floor to live questions with Dr. Cook, I'll invite you all to take this next poll to let us know if we can provide further information about Claris wireless ultrasound. Do click on as many options as apply. Pricing and availability vary by region, so please feel free to request a quote and pricing. You may opt to speak to one of our experts about the advantages of wireless ultrasound. If you'd like to discuss features, please select that option. You can also book a virtual one-on-one demo with our clinicians to see the new Claris HD3 in action in a highly interactive session. And we can send you short video tutorials from our Claris classroom featuring Dr. Cook. Please go ahead and select as many options as you wish. While you complete the poll, I'll take a minute to introduce you to Claris HD3, the world's only third-generation line of portable ultrasound scanners. Now 30% smaller, lighter, and more affordable, Claris delivers best-in-class wireless ultrasound imaging with an easy-to-use app that's powered by artificial intelligence for your Apple or Android devices. Our line of Claris scanners are specifically designed to deliver best-in-class imaging for a variety of applications, and today we're focusing on the phased array for superior cardiac imaging. With fast frame rates, the Claris PA HD3 is amazing for rapid cardiac exams at the bedside. With a small footprint and deep imaging, the PA delivers high-definition window into the chest and abdomen up to 40 centimeters. It's the leading choice for medical professionals looking for premium cardiac imaging in a versatile handheld scanner. And it's also great for EFAST exams, lung evaluation, superficial and transcranial imaging. I also encourage you to request a virtual demonstration so that you can see the Claris C3 HD3 multipurpose wireless scanner in action for full body imaging. The secret to Claris lies in our design, with 8 beamformers, 192 elements, and artificial intelligence that together deliver the image quality only found in compact systems, but at a fraction of the cost, representing about 85% savings. And with AI replacing complex knobs and buttons, it's as easy to use as your smartphone. Claris is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. It fits in your pocket, and you get free movement with no wires getting in the way and touching your sterile prep area. With no wires, Claris is also much faster to clean, disinfect, and you can fully encase it in a sterile bag. Only Claris delivers wireless scanners with an ecosystem that includes an easy-to-use app for iOS or Android devices for unlimited users. Available with our membership, Claris Cloud can be used to easily capture and manage unlimited exams from anywhere. Or you can seamlessly save images and videos to your PACS server through the current DICOM web standard. Your membership also includes in-app Claris classroom videos with experts like Dr. Cook and onboarding with a clinician. And Claris Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. Available with membership, the Advanced Primary and Critical Care Package offers additional AI-powered tools, specialized presets, and automated workflows for common generalized scanning for fast, EFAST, and whole body imaging. It includes the popular Auto Preset AI that streamlines workflows by automatically recognizing anatomy being scanned and switching to the most optimized preset. We'll now close off the poll in 3, 2, 1. Thank you. If you've asked for more information, we will get back to you in the coming week. I'd like to now welcome back our clinicians to answer your questions. Please use the questions icon in the menu bar to ask your questions. Dr. Frankel, I'll invite you to moderate, please.
Yeah, my pleasure. Great. We have a good amount of time here, and I'm going to try and get through as many of these questions as possible. Tom, the first question that always comes up is how can people learn more, particularly around learning pathology? You showed us those pathology slides, but how do people keep updating their skills so they know how to interpret pathology?
Well, this is an old joke. The guy walks down the street in New York City and comes up to the corner and sees this old man, and he says, "Excuse me, sir, could you tell me, how to get to the Met?" Or and the guy sits there, looks at him, and he says, "Well, practice, 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 son." And obviously, you take the transducer and you go and see patients and you learn. That's why we do residencies. That's why our business is called practicing. Where do you practice medicine? And it's a continuous process of use. So what's wonderful about this particular technology, this Clarius system, is it's cheap, relatively speaking, and you stick it in your pocket. It feels great. And you put the thing in your back pocket. It feels like a wallet, or you put it in your lab coat. I carry mine in my lab coat and I just walk around. And as I'm getting my history, I examine the patient. And so you'll do that. Now, if you'd like to learn, more in sort of a didactic sense, go to some courses or look at some online educational content. Third Rock, my company, does online educational content. We have tons and tons of stuff that you can make avail yourself of, or join us at one of our courses and spend some time with us. There's nothing. The thing about ultrasound, as you know, Ron, is it's a manual thing, and you have to have somebody sometimes just hold your hand and just move it a little bit until you get, oh, okay, that's how I do that. And it seems like magic at first, but it doesn't take that long, and you pick up a couple of things. Even me, 27 years in this, every time I do a training lab, I learn something. I learn something from my students. So that's another great way to pick up information.
What do you think about doing this kinds of resuscitation guided or resuscitation ultrasound in the field outside of the ER, like pre-hospital care?
So we're actually doing some pilot studies here in South Carolina. People are very, very interested in it. A lot of paramedics have been taking our courses. We started doing some stuff with paramedic units. Most of them seem to grasp it very, very easily. Of course, the Clarius system and the software are very intuitive, and it's not hard at all. And you're giving them some very basic things. You don't have to be a rocket scientist to, get a view of the heart and say, well, that thing beats fine or that thing beats terrible. And also some other things we're doing with pneumothorax or free fluid. So this is a huge opportunity, particularly with the ability of this system to sort of dumb up and dumb down, if you will. So you can make it very simple and just ask a couple of questions. And because of its archive system and the way you can move the information, of course, this can be forwarded on to a tertiary care center, and they can say, this is what I have. Do you want me to come to your facility? Maybe in the future it would be used for as a measure of termination of resuscitation. Of course, EMS units do that. But, I could see a future certainly where they'd say, let me just see the ultrasound of the heart. And they go, yeah, that person has died, and you could stop resuscitation. So there's a whole new world out there that's waiting for us to integrate ultrasound. And I can tell you that they're incredibly interested in it. When they come and take our courses, they're very excited about it. I think they're the most enthusiastic students we have.
The pre-hospital clinicians. Yeah, I agree. So maybe along those lines, I'm going to try and kind of group these questions together about when do you, because I know there's some dispute in the emergency medicine and resuscitation world around where do you integrate the point of care ultrasound into your ACLS algorithm? Some people say don't even use it sometimes because they worry about CPR quality. Others say, well, we want to look for reversible causes, like you said. So how do you kind of integrate it into your cycle?
Well, as anybody who's been in a code knows, it's like a feeding trough. There's the patient, like 8 people around them, and they're all trying to get in whatever it is they're supposed to do. There's always 2 or 3 medical students around where I am. They want to do something with a resuscitation. So, and yeah, somebody's doing compression. So again, a great tool, right? What do you got? You got something in your hand and a phone. You don't got to wiggle in a cart and try and do all that stuff. But there's really plenty of times, because everybody knows there's always a pulse check. So when they do a pulse check, you just simply put the probe down and everybody's feeling for a pulse. And I go, there's nothing. And usually they just stop. Or sometimes I go, yeah, it's beating fine. And then suddenly go, wait a minute, oh, there is a pulse. So I get a lot of these things as well, where they go, oh, I didn't really feel it, but now I do feel it, because you could see the heart beating. Of
Right.
course, some people are doing TEE stuff, which is very exciting and very cool. I guess, the problem is that it's a big footprint. It's a cart-based system. You got to have a lot of room. Sometimes these people rest in, very small rooms, and it just causes a problem. But I have not personally found it to be a problem. And particularly in those cases where people don't really quite know what's going on. Maybe there's some crazy rhythms on the monitor and you're a little confused. It just clears things up. And it only takes 10 or 12 seconds to do this. So it's not like you're stopping all CPR.
Yeah. And my two tips that I bring up when I'm teaching also is I frequently go subcostal. It's one of the few times I go subcostal, so I don't get in the way of CPR. And I always have a towel in my other hand, because if you are going parasternal during that pulse check, wiping off the gel is a real thankful thing to the next person doing CPR. They're going to slide off the chest when they try to go back in then.
Yes, great points.
So what about, this is maybe a little bit in the weeds, but it comes up a lot about tricuspid pathology, particularly around interpreting the IVC in the setting of resuscitation. How do you kind of assess for that, or help it, or use it to clarify your information?
Well, I'm assuming, and I'm just guessing, if you're talking about tricuspid pathology in the case of obstructive shock relative to pulmonary embolus, and if you're using that to help,
or maybe, or as using it in caution, right? Like if you have a huge IVC, a fat IVC, if they have bad tricuspid pathology to begin with, then you're going to have kind of a false positive. They could be even having low volume, but if they have such a bad tricuspid valve, their IVC is really fat in the setting of other signs of maybe hypovolemic shock. So how do you kind of incorporate all that?
Well, you would use color Doppler, first of all, to differentiate what you're dealing with. I haven't personally seen a case of tricuspid stenosis. You barely see mitral stenosis in the first world. And so if you saw a tremendous amount of tricuspid regurgitation, or if there was something drastically wrong with the valve, those are relatively rare situations. Now, of course, if you have obstructive shock from a large pulmonary embolus, you're going to see tricuspid regurgitation, and that actually argues for your diagnosis. That helps you differentiate. And then the other side of it is, what's the left side of the heart got? Is it small and puny with a high ejection fraction? That gives you information that, hey, I'm not getting enough preload over there, so I still have a problem of hypovolemia. If your tricuspid valve is completely incompetent, well, then you still have a low volume, so you still need to increase preload. So you're just going to have to push more volume through there to try and do it. But that could be a tricky thing to try and figure out. If your left heart is small and your right heart is big, the differentiator here would be the right ventricle would be small, the right atrium would be big. But again, those are far and few between. The old thing we like to say in medicine is, when you hear hoofbeats, think horses, not zebras. And by far, large pulmonary emboli are much more common than totally incompetent tricuspid valves or stenotic tricuspid valves.
Okay, maybe last question is, if you see PEA, but you see meaningful cardiac activity on the ultrasound that kind of aligns more with profound hypotension, even if you don't feel a pulse, are you still, doing CPR, or are you sort of treating that person as severe shock and just reaching for pressors?
Yeah, so ACLS will tell you to continue to, and I agree with that. You continue to do CPR, even if we've all been there. You'll see sinus rhythm, but you don't have a pulse. Now, the beauty of ultrasound is you have maybe a sinus rhythm or some sort of a perfusing rhythm on the monitor, but you don't have a pulse because you're going to look. And if you look and it's just this weak anemic heart that's not going to generate a blood pressure, yeah, you continue with the CPR. I would use epinephrine. I don't necessarily would use pressors if I don't have good enough myocardial activity, a good enough contraction. Now, the flip side of that is you've got very, very good contractility in the heart, but you're still not generating a pressure. Then you may use, pulse a small doses of vasopressin or norepinephrine or something like that. But in general, that's the beauty of ultrasound. You can have all kinds of rhythms on the monitor. It doesn't mean a damn thing if the heart's not pumping effectively enough to generate a pressure.
Great. Okay. Well, thanks so much for that. We're at the top of the hour here. And for all of those questions that we weren't able to answer, we'll be following up with those. I'm going to hand it off to Janez to finish this up here.
Thank you. You'll also all receive a PDF copy of the slides and a link to the webinar recording. So do keep an eye on your inbox. I'd like to thank Dr. Cook for sharing his best practices, and a very big thank you to all of you for joining us. If you missed the first 2 webinars in this cardiac series, we invite you to visit clarius.com/webinars. I also encourage all of you to complete our closing survey to provide feedback so that we can continue to bring you educational webinars like today's. Until our next event, keep scanning, and thank you for joining us.
Thanks, everyone.
Thanks, everybody.
Bye-bye.